Good morning, good afternoon, and good evening, depending on where you are in the world. Welcome and happy World Kidney Cancer Day. Welcome, everybody. And thank you very much for joining our invitation to join us. I'm honoured to co-host today's 2025 International Kidney Cancer Coalition Patient and Caregivers Symposium. My name is Steve Poynton, and I'm a kidney cancer patient since 2016. I've been involved with patient advocacy since 2018 when I joined the team Action Kidney Cancer in the UK. And in addition to this, I joined the board of the International Kidney Cancer Coalition in November 2024. This year's World Kidney Cancer Day theme is Show Your Kidneys Some Love. This is a subject that was particularly prevalent in our most recent World Kidney Cancer Global Patient Survey. We are joined today by three leading experts in the kidney cancer and kidney disease field. But before they are introduced by my co-host Claudia, we are pleased to present a video produced by the International Agency for Research on Cancer about the global burden of kidney cancer.
Hello, I'm Ariana Znaur, epidemiologist working at the Cancer Surveillance Branch of the International Agency for Research on Cancer. On the occasion of the World Kidney Cancer Day, I will be presenting some data on kidney cancer from our Globocan 2022 database. According to Globocan estimates, in 2022, there were more than 430,000 new cases and 156,000 kidney cancer deaths worldwide. There are several established risk factors for kidney cancer, some of which can be prevented. Most important of those are obesity and smoking, which combined are responsible for about 40% of kidney cancer cases globally. Over half of the new kidney cancer cases globally occur in Europe and Northern America, and about 1/3 in Asia. Mortality distribution is somewhat different, with low and middle income countries having larger share of global cancer deaths compared to new cases. Kidney cancer incidence rates worldwide vary widely, with the highest incidence in North America and Eastern Europe, and the lowest in parts of Africa and Asia. While these geographical patterns are consistent in men and women, men have about twofold higher incidence rates in most countries. Looking at the 5-year prevalence, the estimated number of people living with kidney cancer diagnosed within the last 5 years is close to 1.4 million, of which 1/3 are in Asia, 1/3 in Europe, and 1/5 in Northern America. Due to population aging and expansion, we expect a large increase in the kidney cancer burden in the next 30 years, most pronounced in the global south. This will likely be exacerbated by increasing incidence trends that have been reported from these regions. In view of this predicted increase of kidney cancer cases, primary prevention, in particular for obesity and smoking, is really important, as well as strengthening healthcare systems, in particular in low and middle income countries.
Hi everyone, and happy World Kidney Cancer Day. My name is Claudia Ungarelli. I'm Vice Chair-elect of the International Kidney Cancer Coalition and a member of the leadership team of the Italian Kidney Cancer Association, Anture, and a carer for my father, who is a kidney cancer patient. As mentioned by Steve, I'll be your co-host today, and I would like to introduce our fabulous panel members. So we have Dr. Michael Jewett, who's professor of surgery, urology at the University of Toronto and a retired uro-oncologist with a 49-year-long career at the Princess Margaret Cancer Centre in Toronto, in Canada. And he's the current chair of the International Kidney Cancer Coalition. We have Dr. Eric Jonash, a medical oncologist at the MD Anderson Cancer Center with over 20 years of experience in the treatment of kidney cancer and VHL disease. He's the chair-elect of the IKCC and is currently serving as the chair of the Medical Advisory Board. We have Hala Abudeya, who's a professor of medicine at the section of nephrology at MD Anderson Cancer Center, and she's the director of clinical research of immune checkpoint inhibitor for renal toxicity. And then we have Steve, our co-host, Steve Poynton, who serves with Action Kidney Cancer, a UK-based organization, and is board member of the IKCC, and is also a kidney cancer patient from the UK, and is a person-centered counselor that works closely with cancer patients daily, helping them through their cancer journey.
In addition to our conversation today, we just wanted to point out to you that all our experts are available for live questions in the chat facility as you are watching this video.
So in September 2023, the IKCC launched the 4th Global Patient Survey. Thanks to 2,700 patients from across 46 countries, we have now clearer pictures of how kidney cancer is affecting people worldwide. One message out of that survey came through loud and clear. Patients are worried about their kidney function. So this is why this year World Kidney Cancer Day campaign theme is Show Your Kidney Some Love. Let's look at what the data tells us and what it means in real life. So the latest global patient survey shows us that 1 in 5 kidney cancer patients, which means 21% of survey respondents, had kidney problems before they were even diagnosed with kidney cancer. This lines up with other studies that shows that up to 45% of patients with kidney cancer have already some sort of chronic kidney disease.
So these numbers challenge the myth that kidney cancer appears out of the blue in otherwise healthy kidneys. Instead, they point to a silent and indigenous decline in renal function before cancer is even detected. So I wanted to come to you first, Dr. Jewett, and ask for your thoughts on the findings of the survey and the percentage that Claudia has just discussed.
I think it reflects my clinical experience that when a patient presents, and just to be clear, most patients that are diagnosed with kidney cancer start their journey through the urologist in the community, meaning that they've had some finding. Often nowadays an imaging has been done, sometimes even for a completely different reason. They've got an ache or a pain or something that doesn't appear naturally to be the kidney. And the urologist, therefore, in assessing this finding, will, as soon as it's clear that there is a mass in the kidney or some other indication of kidney cancer, will start testing for the background kidney function. Often patients don't present with a history of kidney disease, and these findings are a first-time finding. And obviously it's going to link to subsequent treatment decision-making. So we'll come back to that.
Yeah. Dr. Jonas, your thoughts? I know you may come into this later with your side of your profession, but have you got any thoughts on this subject?
Well, it makes sense, chronic disease in general of many kinds accumulates as we age. The median age of diagnosis for individuals with renal cell carcinoma is in the early 60s. And we do also know that things like obesity, high blood pressure are linked to a higher incidence of renal cell carcinoma. So it's logical that these individuals who are diagnosed with this may actually already have chronic kidney disease. So this all fits in very well with the package that's often associated with the diagnosis of kidney cancer.
Yeah, and Ala, I assume we know assumption can be the wrong thing at times, but you will see patients who aren't diagnosed with kidney cancer at this early stage too for chronic kidney disease. What are your thoughts on this stage?
Yes, I agree actually with my colleagues that it is something that we do see on diagnosis, unfortunately, and especially with an aging group and higher risk of cancer. And as Eric mentioned, with polycystic kidney disease, for example, patients do have chronic kidney disease and do develop cancers. And so it's a kind of a bidirectional relationship where it could be, what came first. So it is a challenge, and typically in my practice, I do get the referrals when they're diagnosed with the cancer, as far as having chronic kidney disease and trying to optimize their care going through this journey.
Is that something that you find common, that if somebody gets diagnosed with kidney cancer, you will get a referral quite quickly for the kidney disease side of things?
I think I do for the most part. There are times that the patients have had the chronic kidney disease for a long time, that they kind of have their, primary care or even their oncologists are comfortable starting treatment. But along the lines after treatment or after surgical intervention by the urologist, I am consulted. So it depends on the severity. It depends on how educated the patient is too. But for the most part, yes, I do get the referrals when they're diagnosed with the cancer.
Okay. That goes quite at odds with my experience in the UK. So I'm going to throw it out there to Dr. Jewett, really, Michael. As a urologist of diagnosing somebody with kidney cancer, would you automatically refer to a nephrologist or an expert in kidney disease, or would that something you would manage yourself with the patient?
I think there are two sides to that. The first is that if in the screening there's no abnormality of kidney function detected, then there would be no need to involve nephrology or internal medicine or someone with special skills in kidney function, unless, and this is the other part, the treatment is going to have a major impact on kidney function. So, for example, someone may have one kidney and it has a tumor in it, or someone may have an abnormal kidney on the other side, or the degree of kidney, the decrease in kidney function would mean that even losing part of one kidney might impact the general health of the patient. So it's very much on an individual basis, but given that the majority of people with kidney cancer present with a smaller mass in one kidney, and the majority of patients have no abnormality of overall kidney function, it is not usual to involve an internal medicine or nephrology specialist at the beginning.
Excellent. And before we sort of finish up on that subject, I was wondering if any of the three of you got any further comments you'd like to make on this particular starting subject.
Yeah, just very quickly, in my practice, what will happen is if an individual comes to me for the management of metastatic kidney cancer, and they either have a worrisome baseline abnormality in their kidney function, or because, and we'll talk about this more, the medicines that we use in oncology to treat advanced renal cell carcinoma may induce a problem, that will be the point at which I will then, or my team will then make that referral to someone like Dr. Abudaya.
Perfect. So now if we go back at the results of the 2024 IKCC Global Patient Survey, we can see that 61% of patients experienced kidney-related issues. 6 in 10 patients experience kidney-related issues. Among these, the most common was proteinuria, so protein in the urine at 21%, and 39%, the highest percentage, was associated with reduced kidney function. And roughly about 25% of patients, so one in five patients completely, and 40% of patients to some extent, had reported that their kidney function impacted their treatment choices. So, and here we can see that the degree of the impact varies drastically by country and therefore by care setting. So why it matters is because kidney function isn't just a side effect of therapy, it seems also to be a determinant of access to certain therapies. And for patients with compromised kidneys, treatment plans might be delayed, downgraded, or altered. And imagine having to choose a less effective cancer treatment, not because of the cancer itself, but because your kidneys can't handle the standard of care. That could be potentially the reality for many patients.
So these findings shine a light on how important renal impairment reshapes the entire cancer pathway for a patient, turning an already difficult journey into an even more complex one. So I have a statement for you, experts, and I want to know your opinions on that or your thoughts. Is it time we acknowledge kidney function as not as a footnote, but as a frontline factor in treatment planning? And I'm going to come to Eric first, if that's okay.
Absolutely. It will, as we think about what treatments to give to individuals, the baseline kidney function is going to temper how we think about therapy. Each of the treatments that we use in advanced kidney cancer, and there's three major classes of drugs. We have immune modulating agents or checkpoint blocking antibodies. We have TKIs or targeted therapies. And then we have hypoxia-inducible factor 2 alpha inhibitors, HIF2 alpha inhibitors, and especially the first and the second. If not at the beginning of the treatment, definitely during the treatment journey, these a decline or a baseline level of kidney function will influence how we think about these agents and can influence how much and how long we can use these drugs.
So how much do you think should be educated to patients from early stages? Once we know that we are past urology, for example, and we need to go into medical treatment, how much, and I guess this might be a slightly off-topic question, how much should patients know early on so they know what they can do to help with their treatment?
A lot, and the theme of this World Kidney Cancer Day is give your kidney some love, and I think that all patients have to give their kidney or kidneys or kidney, depending on what Dr. Jewett has done from an operation perspective. This remaining kidney function has to be watched very closely. And a lot of different things. Number one, as you're moving forward in your treatment journey, managing things like high blood pressure, managing things like weight, managing things like cholesterol, all of these things that can actually influence kidney function, maintaining good hydration. But we can talk about this, and Dr. Abudaya can give us some guidelines there. But just making sure that you're well hydrated. All of these things at the beginning of the journey, exercise also, are really important because as we move forward, by having optimized kidney function, we have a higher probability of being able to continue therapies in an optimal manner.
Yeah, perfectly understandable answer there. So if I come to you, Dr. Abudaya, going back to the original statement I read, is it time that we acknowledge kidney function not as a footnote, but as a frontlining factor in treatment planning? I'm going to assume you're well aligned with that in your area of work.
Yeah, I mean, I totally agree, and it is of importance because it gets the patients do have a lot of anxiety associated with chronic kidney disease to begin with, concerns of progression to needing dialysis, God forbid. And so it's always reassuring to them if they are directed in what they need to do, as Eric mentioned. I mean, optimization of their kidney care if they're diabetic or hypertensive to begin with. I mean, we need to focus more on that. I've had patients personally that when I speak to them about their kidney disease, explaining what a glomerular filtration rate is, where do they stand with their kidney function at baseline of diagnosis, how is that going to be impacted by possible treatments? And so that first visit can open their eyes to the reality that, hey, I am a diabetic. I need to control that better now. I really need to exercise. I need to hydrate well. And then, it can also backfire where they can say, oh, I need to hydrate too well. And then we end up with electrolyte abnormalities or low sodium. So I have to kind of calm them down and say, okay, well, this is where you're at with your kidney function. These are the restrictions as far as dietary restrictions if needed, of high potassium diet, lowering your potassium intake, lowering your sodium intake. I think it is important at diagnosis to give them that education and that information, to guide them through their journey, and to help optimize all the possible issues that may happen, their kidney function, to prevent further toxicity and progression. So that's what I explained to them at length at the first visit. So yeah.
Yeah, and I guess if we move on to Dr. Jewett, when I go to my own personal diagnosis story at the very beginning, I personally had never heard of kidney cancer when I was first told about it, but I assumed that it was related to kidney disease because I'd heard of that. But I can probably count on one hand how many times I've had it discussed to me about kidney disease resulting after kidney cancer. What do you find when you originally diagnose people know about kidney function, or even the difference between kidney cancer and kidney disease, to make it quite a simple question?
This whole issue is common across all cancers. And for example, a lung cancer, in the discussion of the treatment, is going to be the impact on breathing. A cancer in the liver, the impact on liver function. So there is a lot of common ground here. The fact that you weren't aware or that you hadn't discussed it, I don't think should be connected as a straight line to this wasn't a factor in all the recommendations that you were getting. I think sometimes it's so obvious to the clinician that this is important, and I don't mean to defend the profession particularly, but it is so ingrained in the decision making that I think sometimes it just doesn't get as discussed as you might have thought. The other comment that I'd like to make is this concept of baseline kidney function. So the baseline is going to be the level of kidney function when each treatment decision is being considered. So for example, if I see a patient who has a new kidney cancer previously undiagnosed, there will be a level of kidney function, and I will consider my treatment recommendations based on the impact of those treatments on that particular level of kidney function. So for example, if it's normal, there's really not a concern about removing part of one kidney, or even for that matter, the whole kidney. Conversely, down the road, if a patient develops a metastasis or has a metastasis at the time of initial diagnosis, is going to need further treatment with systemic therapies, then after the surgery, there will be a new baseline. There might be a period of recovery from the treatment, but there will be a new baseline. So at each point in the journey of a patient, we are going to establish the baseline kidney function for that treatment decision. And then in long-term follow-up, as we will mention, it's important that we continue to monitor the kidney function, if for no other reason than reassuring patients and ourselves that there's no long-term impact, which generally there isn't. It's usually a new baseline that continues.
Yeah, perfect. Really.
Thank you very much. So if we go back to the data of the global patient survey from IKCC tells us, we can see that at the answer, have your kidney function issues affected your treatment choices or decision, we see that 39% of respondents said that their kidney function changed as a result of their treatment. And although, so here at the global level, we can see the percentage, 39%. And 39% percent of patients, 19 plus 20%, reported that they were always or almost always concerned about their kidney function. Yet, if we go to the next slides, we can see that only 27% of respondents felt completely informed on what they can do to protect their kidney health. And to this end, IKCC has built the World Kidney Cancer Campaign for 2025 around protecting your kidneys, and Give Your Kidney Some Loves is the theme of this year. And we have compiled a checklist for patients to use when they are meeting with their healthcare professional, which can be downloaded from the World Kidney Cancer Day website from this year.
So why does this matter? And I guess before we move into why this matters, I'd just like to remind people that we have our live chat facility going at the moment, where our experts are more than willing to answer any questions or thoughts that you may have. But why the data that Claudia has just mentioned matters is there's clearly from those statistics a disconnect between anxiety and empowerment. Patients carry the emotional burden of uncertainty, something I hear every day in my line of work, yet they lack clear, actionable guidance. The gap can lead to poor self-management, fear-based decisions, and missed opportunities for prevention. Patients are telling us loud and clear, we're worried, but we don't know what to do. This is where healthcare professionals and patient support groups must step in, not just with treatments, but with tools for confidence and clarity. Kidney health is a lifelong journey, and every patient deserves to feel like an active, informed participant in protecting their organs, not a helpless bystander. We spoke a little bit already about education to patients, but those statistics clearly show that patients are telling us they want more. Dr. Abadaya, how would you like to see yourselves in the medical professional and patient organizations, because they clearly have a part to play here too, to help give patients what they're asking for?
I think I totally agree. There is a lot of anxiety about kidney disease and not understanding how the level of advanced kidney disease or not the patient has. So I think it's useful that when we do meet them as a nephrologist, that we first explain the overview of what chronic kidney disease means and the stages of chronic kidney disease, and how stage 3, 4, and 5, which is an estimated glomerular filtration rate of lower than 60 and much lower than that, would be, where they stand at baseline. And with treatments, depending on my colleagues and what they do, either a nephrectomy or targeted therapies or immunotherapies, let's say, how that affects the kidneys. I think, for example, for immunotherapy, we have developed handouts in our institution that explains to patients what to expect from immunotherapy, toxicity of the kidney, how they can be aware of those injuries, what are the first indicators, if any, because kidney disease in itself, patients are asymptomatic. They don't know that they have chronic kidney disease or they have an injury of the kidney. There's no pain associated with acute kidney injury. And so knowing that when they get a blood work, what do they look for? What is a creatinine? What is the BUN? What do those mean would be of importance, and how to watch out for the toxicities from the different medications that we use. And so like the tyrosine kinase inhibitors, the targeted therapies, we look out for the proteinuria in the urine. They can watch for their blood pressure that can go really high and need better control, inflammation, swelling, edema that we call swelling in their legs, and so on. And I know with Eric, they see a lot of these and they manage them, excuse me, pretty well. But we do follow along and try to optimize. And I think from my standpoint, I try to ease the anxiety if there is some kidney injury associated with the treatments. to say we need to prioritize your cancer care, but at the same time, we are watching your kidneys as much as possible. Between the oncologist and I, we try to optimize their care of the kidney health as we go along the journey.
Perfect. I mean, Eric, if we touch on another side of this, as I said, when we looked at why it mattered, as chair-elect of a global coalition of patient organizations, what role can patient organizations play in this?
Obviously, the education is critical here. And, as we've already talked about before, this is clearly a problem. This is clearly something that can impact the quality and quantity of life of individuals. And so by creating a toolkit that patient organizations can then help disseminate to patients, I think this is a very clear way that we can decrease the burden of kidney cancer on individuals worldwide.
Yeah, absolutely. And I think it's a teamwork thing here, isn't it? It's not going to be patient organizations on their own, or it's going to be medical professionals on their own. It's working together to help get that education through.
Thank you very much, Steve. So when it comes to the topic of kidney health management by patients, to the question, have you done any of the following to help manage or improve your kidney function? Patients here could choose all those changes that applied to their cases. And we see that nearly 90% of patients have taken steps proactively to support their kidney health. And many patients report drinking very large volumes of water daily. 66% of patients gave that reply. 46% of patients said that they avoid certain medications, and 14% of patients said that they made dietary changes to what they were eating. However, some actions might be extreme or uninformed. We see that relatively low number of patients, 37%, said that they will consult with a specialist kidney doctor, a nephrologist. So it seems like that the data suggests that patients are motivated and proactive, yet they might be operating without medical guidance. So the risk here is misinformations or habits that are unnecessary and that lead to potential additional health complications. So the opportunity here is to leverage this information gap with accurate information. And this is a very, very interesting findings of our survey, that patients are not passive. They want to do something about their kidney health.
Yeah, as you say, Claudia, but they want reliable, evidence-based. Good intentions can lead to harmful extremes, as we've heard. As a community, we have a responsibility to meet patients where they are, eager, engaged, and equip them with clear, credible strategies to truly support their kidney health. So, Ala, I know you've touched on some of this already, but I guess, is there anything you can add to this to support these statistics? I guess one of the main, as evidenced in the survey, is the drinking more water area. And you touched on before that sometimes people can go too far with that. Do you want to elaborate a little bit on that for us?
Yes, and I think, having a cancer diagnosis to begin with, is already anxiety is associated with that, and trying to do the best they can. But all they hear from people, drink more water. Well, I tell my patients it's the total amount of fluids. And if you're drinking up to 2 liters a day, that's good enough. Don't overdo it. Especially if these patients have other comorbidities, such as heart failure, already on diuretics for other reasons. So it's kind of counterproductive to do that. So I think tailoring to what patients' needs are, depending, it's individualized to what the patient's overall condition is and other diseases that they have. So we do say drink water or drink fluids in general. It doesn't have to be water. It doesn't, and then there are patients that come and say, well, I have chronic kidney disease. I have to restrict my diet. Is there any recommendations? Do I need to restrict protein intake or lower potassium intake or sodium? Depending on how advanced their kidney disease is, then I would do the restriction. But for the most part, I try not to, because they do go through a lot of therapy and they have poor appetite or not able to, keep food down, or nausea as a side effect of some of the targeted therapies, or diarrhea. And so I try to tell them my priority is to get your nutrition up. Don't worry as much about, restricting. Let's see how much you're, eating and how much you can maintain. And if there's electrolyte abnormalities, we can always, start restricting or giving medication that helps, or even modifications of the current medications that could cause high potassium, for example, some of our antihypertensives. So there are different ways of working around this and helping the patients out and educating them about, that the priority here is the well-being of the patient and not to feel burdened by the diagnosis of chronic kidney disease on top of the cancer, and trying to make it an easy journey for them overall.
Yeah, perfect. I mean, Claudia, I'm going to turn on you a little bit. I know you're our co-host today, but you're also a caregiver for a kidney cancer patient, your dad. Bringing together some of the things we've heard, would you say that aligns with your experience?
Well, yeah, when I go to my father's metastatic journey, he has been on a combination therapy for a little bit over a year now. And only recently, for the first time, they found a significant proteinuria. And this has raised questions about whether his kidney function had been impacted by treatment. But yeah, there was really not baseline to compare it with. And I have to say that this ambiguity is emotionally hard to deal with because it's a moment of limbo in which treatment is being paused, waiting to more tests to be done. So I have to say is a difficult phase to navigate. Perhaps the question that was raised is, why didn't we talk about kidney function earlier, since we know that treatments when it comes to the disease of kidney cancer might lead to this type of complications. So it is emotionally a burden, I have to say, difficult to navigate.
Yeah, and we know from a cancer journey the amount of emotional burdens there. Anyway, as Dr. Abouday has already pointed out, the cancer journey and treatment journey is stressful enough. Eric, I wondered what your thoughts are on the sort of statistics that Claudia presented around, and what you experience in your consultation room with people around their concerns on water consumption and all the other things that is expected, if you like, of a patient.
Yeah, I mean, I'll take a step back and just say that the overall sort of anxiety about kidney function and the effect on kidney function of the kidney cancer is a huge issue. So one of the key questions that I get asked when we have our consultation is whether or not the kidney cancer will metastasize to the other kidney. And interestingly, the probability of that happening is rare. Which allows me to reassure individuals about that. But I would say that the concern about the impact of the treatment on kidney function is something that is brought up fairly often by patients and caregivers, and is something that we do frequently have discussions about. I have to say that as a practitioner, I would say that this World Kidney Cancer Day theme is making me rethink how much I actually do talk about this with my patients. And I would say that I'm going to probably be changing my practice and making sure that this is something that I actively ask about, because I think it is pretty clear from this survey that this is one of the main things that individuals who are living with kidney cancer worry about, and is something that I think that we need to have regular conversations on in an ongoing basis. It's pretty clear that the treatments that we give will have an impact on kidney function on a regular basis, and making sure that that we have that dialogue and that we ask open-ended questions in the consultation room about this for patients and caregivers is a vital part of our care for patients with advanced kidney cancer.
And again, and I can say as a patient, that is wonderful to hear that somebody with your experience and knowledge is looking at something that patients have said and is prepared to actually think about your own practice and change it. Because as we heard from Dr. Jewett earlier on, we probably know that it's ingrained in you guys to do what's needed, and we, the majority of us, I'm sure, trust as patients that you will look after our kidney function and do what's needed. But to hear you recognise that you want to do more, having listened to patients, is something that it certainly makes me feel more confident that if somebody with your knowledge and experience is going to do that, then there's a chance that others will follow.
Yeah, and I think this really points to the power of the patient survey, and the fact that by asking these questions, it really does help all of us get educated on what the key areas are that we need to focus on to improve the lives of individuals with kidney cancer worldwide.
And as a real live example to people who fill in the surveys when we send them, and they wonder what we're going to do with that afterwards, that actually we're helping the professionals too, not just the patients. We're helping the professionals. I mean, Claudia, as a caregiver, I guess that means music to your ears too.
Absolutely. Thank you, Dr. Jonas. I think, Eric, this kind of honest reflection is exactly what this campaign aims to inspire. And when you hear a leading clinician say that they will rethink their approach because of what patients have shared, I agree with you, Eric, that this is why the evidence-based data is so important, because it's not just about collating, but speaking of the importance of what matters to people living with kidney cancer. So when clinicians take this type of data seriously, it bridges the gap between the problem that is identified and the clinic, and also what's prioritized by patients. And that's how we move the needle. So it's really refreshing to hear. Thank you.
I think refreshing is the perfect word, isn't it, really, Claudia? So, yeah, thank you. Hala, your thoughts, if you've got any final thoughts on that particular subject?
Yeah, I mean, I totally agree. It does bring to light the anxiety that we could ease for these patients and our approaches when we do meet with them concerning their kidney disease. I think the survey is vital and important. I always felt that the patients had no clue about their kidney disease, and when they meet me, it's the first time they're like, "Why are we here?" And we have a long discussion and kind of a education about what chronic kidney disease means. But this survey is definitely gonna make me bring it up more head on than wait for them to question it. And then the other thing I wanted to point out, back to Claudia's point, with her father, as far as the proteinuria and the diagnosis of that, whether that's therapy related or not, it is a huge challenge in kidney cancer patients, because a lot of them have solitary kidneys, and then undergoing a risk of a kidney biopsy to really definitively say this is related to tyrosine kinase inhibitor or not, or is it immunotherapy induced autoimmune disease. So it does become challenging. And so it takes a team effort between the oncologist and nephrologist to optimize and decide when is it safe or should we do a kidney biopsy, or is it holding the medication, seeing if the proteinuria improves or not? Is it a better way of a non-invasive way of diagnosing? So that's another factor that we look into as a nephrologist.
Lovely, thank you. Claudia.
Yes, Steve, I was actually interested to also hear your point of view. You serve on Action Kidney Cancer in the UK. You are on the board director of the IKCC, and you're also a patient. So what do you think patients' organizations should do with these learnings from the Global Kidney Cancer Survey and having heard real world experiences, having data on real world experiences like yours?
I think it's really important to actually, it's been said before today, but looking at what the data tells us and not going just off our own experience. I know when I mentioned to Dr. Jewett before a little bit about my experience, it was that we can be guilty of that far too often. We have to look at the bigger picture of what everybody or the majority or lots of people are experiencing and not dismissing it because it doesn't conform with your own experience. And I guess sometimes patient organizations can be different sizes. They can be big, small, medium, and especially the smaller ones, I suggest, may get, I know I do, get engrossed in my own journey, my own story. So stopping, thinking, listening to what the experts are saying and looking at what the data tells us, that should direct IKCC, Action Kidney Cancer, in a direction of what people actually need. And I think it's the really brought it home to me today of looking what the evidence says and following the evidence.
Thank you, Steve. Now, going back one moment to what Dr. Abudaya said, I want to thank her for highlighting actually the complexity. As a carer with the situation of my father, I saw firsthand how stressful it is when there is no clear answer. But I think that, what really stands out in your comment is the need for coordinated multidisciplinary care that is present and done proactively, and not only when we reach the crisis mode. And it makes a whole difference for the families that are navigating, of course, this decision. And we really need more system that support from this kind of collaborations between disciplines from the start. Shall we go back to Michael?
Yeah. When a patient is followed up by a urologist after treatment of a localized kidney cancer, the discussion is naturally initially there's no sign of recurrence, or if there is, what to do about it. But at the same time, kidney function is measured. And to echo what Eric said earlier, that I think sometimes we don't communicate that your kidney function, you, the patient, is stable. It hasn't deteriorated because the focus is more on the cancer. I don't want to be defensive about it because I too feel I underappreciated the degree of anxiety that some patients have. And I wonder if in looking at this a little more closely going forward, we might find that there are certain disease states or certain patient characteristics that this is more likely to be a concern. Obviously, if somebody's kidney function is not normal, it's going to be more of a concern. But if someone has normal function and after treatment it stays normal, based on a blood test anyway, then that probably still should be a discussed point. The last thing I wanted to say was that in this process of what we call shared decision making, which is something that the International Kidney Cancer Coalition is very aware of, that patients should be involved in the treatment selection. probably the most common area where this is in kidney cancer is in the localized tumor. And whether the whole kidney needs to be removed or part of it, there's been definitely a major shift towards partial removal or some treatment that's equivalent, such as putting in a probe that can freeze the tumor or heat and kill the tumor, preserving the rest of the kidney function. So in the last 25 years, that has been really the main metric of the quality of kidney cancer. The problem is that partial treatment of a kidney is not necessarily available globally. And in some parts of the world, Europe and North America, for example, this is a standard and the most common form of treatment. But that requires special expertise, special equipment. So just to end, I agree with you, Eric, and with the other comments that this has been a learning experience for me. And I think part of my teachings going forward to my colleagues should be to emphasize this is an unmet need.
Again, as a patient, I thank you, Dr. Jewett, for acknowledging that somebody with your experience and knowledge is prepared to take on what the evidence is saying that patients are saying, because that shows that when we fill these surveys in, the global surveys or any other survey, that actually the people that can change how we're feeling are actually listening. So I want to thank our experts for joining us today to give their informative views and thoughts on such an important subject area. We really appreciate how busy you are, and thank you for taking the time to spend with us on World Kidney Cancer Day. Thank you also to my co-host, Claudia, who plays such a pivotal role in patient advocacy in Italy and globally, and I'm sure that will continue in her new role as Vice Chair-elect of the IKCC. I also want to take this opportunity to thank everybody who supported the Global Patient Survey. We wouldn't have this subject today without that. And it's and your commitment to generating the evidence to help reduce the global burden of kidney cancer. A special acknowledgement to the Global Patient Survey Committee for leading this initiative, and of course the sponsors for making it possible. Finally, though, I wanted to thank you for joining us today, for those that have watched the video, for those that have joined in with the live chat. We thank you for your time as well. We hope you've taken something from the video. Thank you very much.